Well, my first thing that I'd be worried about would be like a reflex inhibition.
Okay. Describe what the reflex inhibition would look like.
So I'd expect them to have like just braking weakness, probably in multiple directions or multiple planes of movement.
Mm-hmm.
And it wouldn't be fatigued. There'd be non-fatiguing weakness, but like braking weakness would be consistent, and it wouldn't match up with like a myotome or a peripheral innervation.
Mm-hmm. You know, it's nice about that. You see that pattern. What does it immediately differentiate it from? Like, because really, you get to this pattern, you're thinking, okay, what are your two likely ones? If you're thinking the etiology of this is reflex inhibition, what's number 2 on your list?
Probably like a segmental facilitation.
Yeah. How is that different from a segmental facilitation?
Segmental facilitation would be more myotomal, and it'd be a velocity-dependent weakness, still non-fatiguing weakness. So.
Mm-hmm. Describe velocity-dependent weakness.
So it'd be when you're testing the muscle with like an increased velocity as opposed to like a static buildup, which you would test for with like a radiculopathy, looking for like a fatiguing weakness. Usually like when I'm testing for this stuff, I'll do looking for the fatigable weakness first, and if that's fine, then I would test like a velocity dependent weakness next.
Good.
And they'd also have like the other things go along with the segmental facilitation, so like brisk reflexes, usually like an increased sensation. The different signs like upper lumbar spine, I guess. Probably
Yeah.
L5.
What would it look like? How would you differentiate that from like, okay, you have weakness here, and you're going to differentiate that. You kind of said some of them, differentiating it from now you're into your kind of your bias correction or making sure that you're not anchoring to a diagnosis. What about the other ones, radiculopathy? How would this differ from radiculopathy?
So you want to, so like if you're looking at even like, if you're looking at like an L5, I guess you could test like hip abductors. You could test for strength there, and if it was radiculopathy, you'd expect same thing, fatigable weakness or braking weakness. Yeah, no, I guess not braking weakness. You'd be looking for fatigable weakness at like L5, and if you didn't have it there, then that would help with like bias correction. But for me, the biggest thing would be like the type of weakness that you're having. Just because like fatigable weakness, I'm expecting at like probably the second or third muscle contraction, and it to be like a drastic drop off, not opposed to like a braking weakness. I'd expect just like very consistent type of like break when you're testing it. That would be the same no matter how many repetitions that you're performing.
Tricky one. This would be like if you let's say you had a neurological weakness, differentiating between peripheral versus, let's say, central or radicular. What would be the indication that would tell you that it's peripheral versus central? What could you do to differentiate between those two? Same segment.
Yeah, I mean, I think you just test something further up the chain that has a different peripheral innervation. Is that what you're looking for?
Which muscle might tell you that?
Like if you're looking at L5, it'd be like glute med.
Yeah, that's kind of what it is. That's what this is basically. If you're looking at clinical reasoning, Eric, how close is this to basically the kind of thought process you need to have on a practical?
We did this stuff literally for what do you guys think? Maybe an hour on Friday afternoon.
Awesome.
Just giving them particular, so ankle dorsiflexion weakness or hip abduction weakness or whatever. We had a whole bunch of them. We did some sensory stuff too, but yes, this is essentially, how we do the differential process between peripheral and segmental, right? And then you just have to look at the particular type of weakness. Is it fatigable or is it consistent? And if you're looking at that sort of stuff, then you should be able to, they shouldn't be overlapping, right? These things should be different enough for you to kind of figure these things out. And Tanner, you should know that if you test a facilitated segment more than like 4 or 5 times, it's going to get stronger, even with the speed dependence. Because essentially, you're giving normal feedback through that dysfunctional reflex loop. And so the strength will actually improve if you test it too many times.
Yeah, because you essentially start treating it.
Yeah.
When you start doing too many times. That's kind of your indication. All of a sudden the strength perks up. It's not that, oh, it's not it. It's like, huh, am I now getting the response that I wanted through proprioception?
How
And
much time passes before we would notice like a meaningful change? Because if you go in, like, let's say it's a, L4 and you go in and do mobilization there,
mhm,
then we retest it because we would expect to see a change, right? So like,
yes.
at what point in time are you telling yourself like, I don't know. I guess
So,
I know what I'm asking.
well, I think what you're getting at is how long do we have to do something like that in order to see the change distributed into the limb, right?
Yes, thank
So as far
you.
as the weakness, how long would it take for it to improve? Not very long, because essentially we could go in and do a manipulation and it's back like that. Basically, you're using that to reset some of the kind of length tension relationships that you have set. I consider this that there's a portion of the midbrain called the periaqueductal gray matter, and it's basically like a Rolodex the body has for these length tension relationships. And the increase in tension across the musculotendinous unit is really what sets off this velocity dependent problem, right? It's that triggering of the GTO, right? That inhibitory process from the GTO, because there's too much tension too quickly across that muscle belly and across the tendon. It's just going to turn it off because essentially it's sensing it's too much, it might break, right? This is a protective mechanism for the muscle belly and for the tendon itself. So you can go in and do a manipulation and have it immediately change these things. With mobilization, it shouldn't take very long at all. Now, the problem with that is it's probably going to be transient, right? You're going to get this kind of automatic neurophysiologic reaction where things improve. And I think this is where that neurophysiologic theory, we talked about this over the weekend, right? The theory behind manipulation, where you're not really you're not really changing anything mechanically speaking, but you're getting this neurophys reaction where you're diminishing all this muscle tone. I think that's probably where some of that theory kind of really took root and started being, essentially a problem for those of us that look at things biomechanically. But you can get those changes very quickly, but unfortunately they're going to end up being a very transient thing unless you actually treat the cause and eliminate the kind of constant, bombardment of nociceptive feedback, right? So it shouldn't take too long. If you did say, a wobble at the segment, for instance, for 30 seconds to a minute, you should notice a change.
And then you can use that as like kind of a diagnostic indicator, like, hey, I'm in the right area. I know it's coming from the lumbar spine and not from the peripheral joint because I did that wobble and noticed a difference.
Correct. As long as you haven't done anything else yet. Meaning,
Okay.
as long as you haven't treated any other areas of the body that might also contribute to a change in the result that you're expecting. But yeah, if you're still going through your assessment, you're saying, well, let's just see if we're working on the right place. You can have them flip over, do a quick wobble on that segment, and then retest your strength, retest some of these other facilitatory mechanisms, and you should see a change. This is essentially, like Dave has been saying, I think Jim says quite a bit in his material. This is part of your bias correction, right? Is making sure that it's coming from the spinal segment. You've only changed something at the spinal segment now. That should give you the results you're expecting as long as your assessment is where it should be. I don't do that very often. I'd rather go in and do my treatment and have the treatment change it. That way, when I'm showing the patient that something has changed, it's like, see, the treatment that we've tried to accomplish is actually has improved some of these things. So you can go either way. It just kind of depends on how you're looking at it. I like to use it for carryover and kind of patient buy-in post treatment, but you can go either way.
I'm probably a little more PT Barnum in that when I know this is coming down the pipe, then I use it to sell. And that if it's okay, with the L4, then I go and do the wobble, and I go back and test your strength, and it's immediately better. And I make a change that immediate, that's seemingly unrelated. What I get from that situation, again, not being cocky about it, but just kind of explaining the problem, you look really smart for a brief period of time. So you want to capitalize on this window of basically patient buy-in. And now what you do is I use it then to buy-in. Now, it may be that they need the 40 minutes of rehab, and the part that I do is the smallest portion of this. but they got to understand now they'll buy into the other things that I want them to do. So once I see that it's reflexive or segmental facilitation, I think it's that. I find that, I find the breaking segmental weakness, maybe the change in reflexes. Then when I go and do the wobble and it improves, they see right away I can do one thing seemingly unrelated to their elbow and improve their tricep strength or their L4 strength. I use that for buy-in because I want to have that patient's confidence. But again, I hedge you to not be cocky about it when you're going to do this, and just still be very patient-centric. And that's something that I was probably more cocky about it earlier in my career. I think there's way more value in getting the buy-in and trust and really putting the emphasis on that portion of it, not just it to be about me putting on the show, as it were. But I use it for buy-in all the time. Same thing with reflex inhibition and how you're going to treat it differently. And again, I will, depending on the individual, I may do the joint. If I think it's a joint segment, I'll wobble the joint first and see if it changes it, or put proprioception into the joint and change it. And then explain to them the process that we have that's going on.
It's also how I get patient home exercise buy-in. So you tell them it's a temporary effect, and the greatest effect that if they're going to do their home program, it's going to be most effective in the first day. And then there's also some things they can do at home to increase their their own proprioception. But it's really, I agree with Dave, it's buy-in for what I do, but it's also buy-in for what they do.
Yeah, and that's maximum value. If you can kind of get both of those. And then, then you have somebody to be a little bit more compliant. Another question about inhibition. Actually, we'll save neutral zone for the next one. Okay, leg one. Let's go with the Tanners today. Newberger, are you out there with the microphone and or do you have the dog?
They're here, but they're being quiet, so we're good.
Okay. I've been 38-year-old male with the shooting pain down the back of the leg. Like here's your basically your illness script. What is your first thought when you hear this?
Some type of radiculopathy is my first guess.
Yeah. Yeah. And a second guess, if you had to have one to put on the back burner?
Oh, maybe something towards like sciatica, something that's a little bit more somatosensory versus that lancinating pain.
Okay, so you're using sciatica more as a somatosensory descriptor, which is fine. It's all in how it's defined because it's such a catch-all phrase using sciatica, which are like the big junk barrel you throw everything into. Okay, differentiation between somatic pain and radicular pain. What's the difference?
The radicular pain is going to be more that lancinating sharp that you're going to get with that obligate loss of function. Somatosensory should be a little bit more diffuse, kind of hard to pinpoint exactly where it's shooting across. And that's not going to result in loss of function.
Okay. Now you got pain down the back of the left leg. Now, this is a classic Jimism here because he doesn't differentiate this from this thing. What would you need to know from this statement that would help you further differentiate between basically, let's say something that's radicular versus referral?
What motion it occurs with.
What motion? Be one. I'm also looking for something else. Look at it. We have a 38-year-old male with shooting pain down the back of the left leg. The question would probably be is how far does this go? It's intentionally vague with him. So it's the quality and where does it go? What is it likely if the pain is going down the back of the left leg? Let's say he's using a leg, or let's say thigh to the knee. What would that be more indicative of?
Be more L5.
To the back of the knee? It's tricky. Okay, how about this? How about the pain goes to the back of the heel? Shoots down my leg and goes to the back of my heel versus the pain that goes down the posterior thigh to about the level of the knee.
I'd be thinking more S1, S2 in that case.
To the back of the knee or to the back of the foot?
Foot.
Yeah. And how about to the back of the thigh is kind of a little bit open, isn't it?
Yeah.
So with that one, what do you need to differentiate with pain maybe going down to the back of the thigh?
See if I'm getting any muscular weakness in some of those back muscles to see where I can differentiate it from.
Yeah. What you're looking for here is you're always in that thing of that difference between, referred pain, like a somatic pain versus radicular pain. So yeah, if this pain is lancinating, it has a different quality. If this pain is, okay, I get dull, achy, diffuse pain, what is it in its nature is what we're looking for, like the electric shooting, and also the length, because pain that doesn't extend below the knee can be a little more vague. It can be referred and then develop into radicular pain at a later date as you get neural irritation. But inflammation around the dura, disc, ligaments, those types of things can also contribute to referred pain. Eric, what do you think about it? You get pain to the back of the thigh. What are your differentiators? How do you view it?
So this is something these guys should know, right? So let me ask you this, Tanner. When we're doing a slump test for the thoracic spine, what's the one specific change that we're making to the thorax? To the test, I mean, for the thorax.
Making it more kyphotic.
Making it more kyphotic?
No, less, sorry.
Less, and why?
We're trying to rule that out of neurological testing.
Right, so we're looking at the thorax being capable of producing radiating pain from a non-neurological structure, right? So what is the difference between, in the rest of the spine here, what is the difference between the thorax and the rest of the spine? It's basically, when we move, the radiation of pain with lancinating pain is immediate, right? You bend forward, bang, there it is, zing, right down your leg, right? Or foraminal compression, we tilt the head back and zing, there it goes, right down the arm. It's immediate, right? Somatic pain tends to be something that requires the sustained position or repetitive movements, right, in order for it to start the reference, right? So this is somebody that goes walking down the street, they get into lumbar extension, right? So they say they have a irritable hypermobility. First half mile, nothing bothers them, right? But as they're still walking, they're getting this constant hyperextension of the lumbar spine. Maybe, they've got a stiff hip, something like that below it. And after half mile, a mile, now they start getting this reference of pain into the limb, right? Probably due to some sort of, hypermobility of maybe the facet joint, right? Something simple like that. So maybe it's the joint capsule itself, maybe it's the articular surface, maybe it's one of the ligaments, so it doesn't matter, right? It's a somatic structure. But these things take time to build up, right? Or somebody that wakes up in the morning that's sleeping on their stomach, right? Or sleeping with their head twisted to the side, then they have pain reference down the arm. Prolonged or sustained positions or repetitive movements, those are what tend to produce these referred somatic pains into the limb, right? Versus a lancinating pain tends to be something that happens instantaneously with the first movement, right? So sometimes you're looking at the quality of pain, right? This is the electric shock, this is the sharp, burning type sensation for more of a neuropathic pain versus these dull, diffuse aching things for somatic pain. But you have to look at the time frame in which they occur as well. Does that make sense? We're all following along. Always good to. All right, Jenna says yes, so apparently everybody's else replying yes as well. Dave, you're muted.
That idea of, yeah, I mean, it's said perfectly how that lancinating pain is immediate, it's positional, comes on, versus that pain that comes on with repetitive activity, and how it kind of differentiates. You can kind of tell what's going on immediately with that. And this question's tough because you get information. So when Jim gives you this history, what he's looking for is that, one, can I differentiate the quality of pain that I have, but also kind of by the location of it. Because if you ask this thing, okay, shooting down the back of the left leg, want to make sure with Jim and say he's referring leg, he's saying lower leg, not thigh. He didn't say thigh, so I could assume it would be going down the leg. But then it's looking for the quality of pain. Is it, as you said, Tanner, is it lancinating? Is it costalgic? Is it a dull achiness? Is it diffuse? To get a sense of, do I have something that's radicular versus something that's referred, and that helps you kind of delineate the structure that you'd be looking for in this case. So if it was, I think you're on the right track, Tanner. So burny, achy, itchy pain, Tanner, let's talk about that a bit. It's the far common on the neuropathic side. Tell me a little bit about this patient looks like if he has basically neuropathic pain that's burning and itchy.
Then we got to look at a few more of the risk factors that patient has, a few more comorbidities, because then you're thinking more of a potential medical condition there.
I mean, it could be in your differentials if you're looking at causalgic, but you're really looking at, okay, I have nerve pain? I have a nerve that's getting compressed, either a nerve, at this point, probably we're looking at lancinating pain being more the electric, more the nerve pain or the root, but there's inflammation that's going on around the nerve, which can stimulate that pain. It could be something pathological doing it, idiopathic, something in that range, but it could also be chronic inflammation, I would say as well. Is that fair, Eric or Rebecca? Your impression of that type of pain pattern, any different?
Yeah, I think that's right along the line there. I mean, when you look at peripheral nerves, they don't typically produce a lot of true lancinating type pain. It really requires a lot of compression and friction for those things, for that epineurium to become so sensitized. But essentially, it requires inflammation when it gets to that sort of thing. So you're looking at something that's had a substantial amount of pressure on it for quite some time.
Yeah. And again,
from my perspective.
Yeah, with this one too, if you're getting into visceral and somatic, I mean, with that, your classic, what would be your classic one, Tana, that you'd see, okay, if this is a visceral pain, how would this person likely present? I mean, when you go to take a look at them and do your testing.
It wouldn't be as consistent as any of those other presentations. It would be more in coordination with some other bodily functions.
Yeah, it's exactly it. It's your scan exam then becomes relatively uneventful, or you don't get meaningful information from it in a way you can see. So, you often don't arrive at this one first unless they're having GI and abdominal things. At least they've had something, an abdominal history in the recent past or an event going on to refer pain, which you can ask for in screening questions. If it's it, your musculoskeletal exam should be relatively negative. And again, unless there's like severe sensitization, but it's most likely they wouldn't. You go and you move the hip or straight leg raise, your other tests should be relatively basically untelling, I guess would be the word I would choose, or make up the word I choose. Chat, what was the chat question? I think scar tissue adhered to a peripheral nerve. This is a good one to hear from Eric and Rebecca on too. With that one, they talk about nerves and nerves being able to develop free nerve endings if they're chronically irritated as one thing, but it's got to be a chronic irritation, and that can happen in the lumbar spine at the nerve root. I think it can also happen peripherally, but if you have scar tissue binding a nerve, your pain there, unless you've developed nociception from some free nerve ending growth in that area, should be, again, peripheral nerve patterns of paresthesias, dysesthesias, or anesthesia, depending on the level of scar tissue that could be bound down to it in irritation. Eric, any thoughts on peripheral nerve scar tissue adhesions?
Yeah, well, I mean, essentially the scar tissue adhesion type thought process just means there's going to be more tension on the nerve in general. It's going to be less mobile, right? So when we're looking at these things, there should be what we consider a constant length phenomenon with nerves, right? They're always the same length. They don't stretch. They don't contract or extend or any of those sort of things. They always have a certain amount of length to them. It's very much a static thing, right? So we should have enough mobility within the system to get our limbs through full excursion into different movements, right? These are what our upper limb tension tests are looking at. These are what the straight leg raises, the slump tests. These are what those things are looking at. So if we have tension on that system, we're going to lose some of that excursion. So the thought process is, if we have scarring, is we're going to diminish that amount of excursion. Now, what kind of symptoms will it reproduce? It really depends on how significant the scarring is, right? Is it within the nerve due to, say, the nerve has actually been traumatized and there was swelling within the epineurial sheath, any of that sort of stuff? That could diminish conduction, right? So you might have, especially in a position of tension, you might have something that reproduces pins and needles, something like that. But in general, it's not something that's going to give you a lot of symptoms when there's slack on the system. right? So if I'm standing in a neutral position, the odds of me having enough tension from scar tissue into one of the limbs is not real good, right? But if I'm bending forward to tie my shoes and I have scar tissue on a peripheral nerve, say around the fibular head or something along those lines, then yeah, I might have enough tension on the system at that point to produce peripheralization of some sort of symptoms. But it should be based on where the scar tissue is, right? So if it's above the fibular head, we would expect it to be a much larger, broader distribution, including the web space in between the first and second toes, because it would include both the deep and the superficial. If it's just the superficial, then obviously we're going to lose that space just in between the toes, and it's going to cut down on some of the area of that distribution. So it all depends on where it is and how much actual tension is on the system for the scar tissue really to be relevant for me. Scar tissue. Yeah, Jennifer, it did say that. Dave, you should know that. I noticed that under segmental facilitation on the first one, the ankle thing, you had fatigable weakness for segmental facilitation.
Okay. I can change the slide.
Probably just a typo, but yeah, I saw that too. Yeah, right down.
Paramount. Usually any presentation Jim has, you'll kind of like me, you'll find 3 typos. So as you pick them out, it's like a word search. Find the error and let me know. My mind, as I read over things too quickly sometimes, is I just filter in what I expect to read, not pull it out.
All right, Isaac. So Isaac's wondering about scar tissue and something like a disc herniation. How do you differentiate? It's the distribution, right? So scar tissue, if it's peripheral, will have a peripheral distribution. If it's a disc issue, it's going to have to be segmental.
Yeah, and the hard part of that many times, Isaac, it may not, it had to be scar tissue that's enough to irritate the nerve. If it's scar tissue that's to inflame the door or the surrounding structures, then you're going to have more referred pain. So again, it's not uncommon to see referred pain that then maybe later develops into radicular pain as the nerve gets inflamed or irritated. But you could easily have that scar tissue in that area that's restricting the segment or creating a problem that's also creating referred pain. But if it's scar tissue that's binding down a nerve, then you probably have a positive neural tension test, is my guess.
Yeah. And the problem with it is you can have scar tissue from a disc herniation, right? The swelling from the disc herniation, this swelling in general will cause scar tissue. It's just the inflammatory pressure that does that to us. And it happens relatively quickly within, was it like 3 days, something like that? You can start seeing that stuff crop up. So again, if you have a chronic disc lesion, right? Something that's just a protrusion, it's not necessarily causing neurological symptoms at that point, right? But it's affecting mobility of the nerve potentially. Over time, can you build up enough pressure, create enough irritation of that dural sleeve? Remember, the dural sleeve is actually more connective tissue. It's not true neurological tissue. So it can refer pain, but it's not going to radiate pain unless it's really sensitized by a lot of swelling. So yeah, after a certain amount of time, you can develop enough swelling where it actually creates scarring around that tissue. So that's true with anything, right? You get surgery on your shoulder here, you get a little work done on the biceps tendon, it's not going to have as much mobility as it should either. Kind of the nature of the game. Healing process. All right, what do we got now, Dave?
Well, basically the next one that they had in there, which was tendinopathy, the 50-year-old right-handed, looks like females covered up here, with left elbow pain times 1 year. And the next lucky fellow up is Drew. Drew, you on there? He is. I saw him earlier.
I'm here. Had to unmute myself.
Yeah, no problem, Drew. How you been, Drew?
Doing well.
Good. So non-dominant 50-year-old female with tendinopathy. Now, Jim on some of those kind of went over this. So you were about to turn in your things to Jim. This is a good one to kind of go through because probably on those it did return it with something. Jim was big on this, and as well is defining, the broader category is tendinopathy. The subcategories that you'll find underneath of it are these 3. Tendinosis. So, Drew, how would you differentiate tendinitis from tendinosis?
The acuteness, typically, and the reaction to like a painful stimuli, I would expect the tendonitis to be very reactive, and a tendinosis typically is a little more of the, yeah, it hurts, it's achy, but not quite as sharp, I guess, to touch on palpation a lot of times.
So when you first hear this history, what's your first thought? You get this history and they're still in the waiting room. What are you thinking? Without taking a look.
I'm thinking with this one is, I would think more of a tendinosis.
Yeah.
It's been ongoing for a year.
Mhm. So doing that, what would be your first couple questions you might ask them? Think of 2 questions that would give you the most value.
Oh, I probably want to know where exactly on the elbow, and if there was anything specific that started different, that she started doing differently when this first came about. You know,
Yeah, I mean, where exactly on the elbow is always a good question. I mean, and again, in this here, it can vary. You know, what are the areas that you typically see irritation with somebody with a tendinosis? We were talking about the elbow. Is it always in the same exact spot, or is it different locations?
typically I'll see that lateral epicondylitis or epicondylosis in that case. I guess you could technically get it anywhere those tendons are at.
Yeah, bonus points. You can see the irritation anywhere along there, and typically where I'll see it is, you know, you have insertional tendinopathies, which are different in their nature and makeup than mid-substance tendinopathies. I mean, typically over there to be on the human, basically right along the humeral condyle and the attachment there. You also have it over the radial head, which can be confusing at times if you're looking at a radial, thinking, okay, is this, you know, a radial head dysfunction or a radial humeral problem versus, you know, epicondylitis, because lots of times the tendon as it wraps over there, and then sometimes just a little distal to it, more in the muscular tendinous junction. You know, you might see it in these individuals. So you can find it along that continuum. Eric, is there a typical location you think you see more than another?
Well, with the true tendinosis, you typically see it more on the tenomuscular junction with something that's actually related more toward like a oscillatory effect. It's going to be more at the the tenoperiosteal junction.
Yeah, I think you do see it down there, and the ones that are higher up, then I'm hoping for a radial head dysfunction. But you'll often find that it'll overlap in the tendon as it goes up, depending on its time and its frame, and how it's been inflamed. You know, when it's higher up along the humeral attachment insertion point, that's the one that lingers for a while afterward. And it's the one they can bang. You know, they haven't had pain for 2 months. They bang it and they get severe pain because it's still hypersensitive at the interface.
Yeah.
So they can have they have slightly different patterns. It's more pronounced in like Achilles tendinopathy, where the insertional tendinopathy is different than mid-substance. It's to a degree in the elbow, but it's not as well studied. But it can be thought of in a similar fashion that you may see it along this continuum. And I think because I see tennis players, I just see a greater variety of these in individuals because they're doing a greater variety of things than, you know, just the average population that comes in there. All right, Drew. So how would you differentiate it then? What would be the 2 tests you want to look at then to kind of see, just to palpate it? So always think in terms of 2 questions. You know, you can think of 3 questions and 2 tests. That's what Jim's looking for. That's kind of what we're looking for when we do the oral practical. So what 2 tests would be the ones that would probably give you the quickest result to kind of rule it in?
Mobility, elbow extension, wrist flexion, reproduction of pain, and pain with resisted wrist extension.
Mm-hmm. So with a let's say a tendinosis, what would the resistance tests look like?
I'd probably expect a weakness, just a consistent weakness.
Okay. Weakness. How about with range of motion? What range would you expect the tendinosis to be sore if it's a chronic one?
I'd expect an end range.
Yeah. So with a chronic tendinosis like this, maybe a little bit more sore toward end range, and it may take a little bit more provocation.
Mm-hmm.
Muscle testing, you know, it can be variable in this individual. sometimes, the first muscle test you do, they may be all right, or the first muscle test you do, it may actually be a bit sore. And then if you're doing repeated testing, thinking, hey, is this some type of segmental facilitation? They may actually you may actually desensitize them a bit. So it can go a couple different ways with, if you're looking at a chronic tendinosis. Sometimes they need to get stirred up a little bit or get irritated. Or this may also be the one too, it's that depending on where they are in the continuum, that may do better with motion. So this one, as Jim will talk about, you're gonna have full, with the tendinosis, it's gonna be full range of motion, most sensitive with the end range stretching and contraction. Tendon tenderness, it could be tender, less tender. Like if I'm comparing this as a different script for tendonitis, I expect it to be really hot with palpation, where this may be achy, but not a high level irritability. But again, Jim will even talk about this with this one. Stretching may also be negative, but the isometric test can be positive, but it's gonna be positive with the tendonitis too. So it necessarily doesn't help you differentiate between tendonitis. But really at this point, we're looking at severity of symptoms and onset. I think having this for 1 year helps. That what biomechanically could cause this? What do you think, Drew? Would you say, okay, if we had a biomechanical dysfunction at the elbow or wrist, or elbow and wrist, what would you think you might see causing this?
An abducted ulna could cause this. So then potentially you could be looking down at the wrist with a radial deviation. You could have a drop scaphoid. It all contribute into this, or potentially be the etiology.
Good. I'm not 100% sold. How about the radial head? Would the radial head dysfunction have any role in this? And if so, which one do you think might put more stress on it? If it's a radial ulnar dysfunction.
If it's a radial ulnar?
Yes.
Because of the location, probably lean a little bit more towards the radial head.
Yeah.
Being directly under it, essentially.
And for bonus points, which direction would most likely put potentially more stress on the tendon, pronation or supination?
Like pronation.
And my vote, I would vote pronation. Eric, thoughts on that one?
I would say it'd be a loss of supination, diminishment of supination. So as you're trying to open that up.
Yeah, and that would be that dorsolateral glide that would be lost. So it'd be a dorsolateral one, which would restrict supination. Yeah.
Well, that'd be anterior medial.
Well, supination. Oh, they'd be the anterior medial glide. Yeah. So it's stuck dorsolateral. With also anterior medial. Yeah. So, and again, if you're at an early point in this, you think, oh God, I don't know which one would cause it. The one thing I'll tell you is don't worry about it. Just assess it. So even in your mind, it's like, I like to think, oh, gee, I wonder which one would cause it. I think this one would cause it. But if I find something different, don't beat yourself up too much. But by doing the thorough exam, you'll kind of see, it's like, okay, I know that I have a tendinopathy here. I'm comfortable this is a tendinosis because it's 1 year. Okay, it's not acutely irritable. I can, stretch the full length. It's not sore until I put, a moderate amount of pressure on it at its lengthened position. So you're really leaning and strengthening this tendinosis thought process. As you look for your biomechanical search for etiologies, you start to think about, I'm going to look at these different joints in these tests to see what I can come up with. So, we look for the abducted ulna, which was ulnohumeral joint. We also mentioned, okay, there could be a dysfunction at the radial ulnar joint. And he also even mentioned a scaphoid dysfunction, which would offset the wrist and potentially irritate the extensors. So even if you're not quite ready to start predicting these injuries, just keep an open mind to know that if you scan all these things, you're going to bump into them and you're going to find these causes. That's where having a system for your early exam is helpful versus trying to go, okay, let me pick the exact test and do one test. This is a 2-minute exam and a biomechanical to kind of check it out. All right, Drew. What else could cause, now we have an extensor tendinopathy. What else on our list of things that Jim has recently been posting on could cause an extensor tendinopathy? That's not a biomechanical dysfunction.
saying like a facilitated?
Yeah. Yeah. Which segment would you expect it to be if a facilitated segment would
Down
cause?
at that level of C6.
Mhm. Cool. So what would it look like?
You would have some hypertonicity there.
Uh-huh.
Your velocity dependent weakness.
Mhm.
And then one that we talked about in class this past weekend is it would actually get worse with cross friction, which would typically be a treatment for a true tendinosis.
When was the last time you used cross friction?
Today,
Really, you took your finger, put it on a tendon, did 5 minutes or 6 minutes of cross friction?
I only did it for 2 or 3.
2 or 3. Yeah, so probably not long enough. But no, I mean,
I don't
cross.
think it's long enough.
You use it 2 minutes for that? For
You just needed to desensitize.
Oh, desensitization. Okay, gotcha. Okay, if you're looking for scar tissue, then I would think it'd be longer. But if you're looking to desensitize the tissue, then yeah, 2 minutes enough. I think the more common thing that's happened with desensitization is it's big in the Midwest. Even is I use ASTIM or any type of instrument assisted soft tissue mobilization. I think it's purely desensitization.
Mhm.
I think very rarely are you ever really impacting scar tissue with that.
No, but you can certainly affect the local hyperemia that can kickstart a stalled, especially in somebody with a 1-year tendinosis. You can kickstart that healing process again.
Yeah, but I think lots of times we use it. Most of the time, it's used for desensitization.
Yeah,
and again,
it works out. I was going to ask Drew something, and I forgot what it was. So you're off the hook, Drew.
Drew, you kind of see how these things are all kind of, these questions and kind of the format is very similar to what we did with the other 2 studies.
I remember what it was. How would their pain present, Drew? Like as far as irritating factors, what's one thing that they might have that somebody with a local pathology might not have?
A correlation between movements at the neck with their pain.
So this is the type of person that says they wake up with this pain, right? Somebody that's sleeping on their stomach with their head twisted around like this all night.
Mm-hmm.
They say, every morning I wake up and I've got this stupid thing here. And you're looking at that like, well, that can't be an overuse issue because you're not doing, unless they're screwing something in their sleep, that's not an overuse problem, right? That's a positional fault. So then you ask them, what position do you sleep in? And when they tell you, well, I'm sleeping on my stomach with this huge pillow propped up underneath my head, you can start thinking, yeah, the facilitatory effect's far more likely.
Mm-hmm. And again, what if it was, how this present if it was radicular?
See a fatigable weakness, there'd be that lancinating pain. I would expect it to be more of the arm than just at the elbow.
Okay. And what biomechanical dysfunction at the neck, if you had to guess, if she had a biomechanical dysfunction, do you think you would see?
Be a hypermobility
Could be.
At the segment.
Okay. Which segment would it be a biomechanical restriction in what direction? Bonus points, because it's not 100% that it would be this. What would be your first inclination? What would it?
The hypomobility on the opposite side, causing a hypermobility on the left side.
Yeah, that's certainly a key finding. I would think first thing you think is by extension dysfunction on that same side.
Okay.
Do you have something closing off the foramen? But the hypermobility one's not a bad bet. It's quite possible. Could you have stress there? So even as I get into this, it's like in my mind I have kind of what I expect to see, but I don't try not to let my bias get in the way of what I find. So I kind of blank slate it when I get in there and kind of look at it and think, okay, I'm kind of expecting I might find this. I'm hoping I find it because I know what I'm going to do for it. But when I don't find it, I don't force it. I'm like, okay, this thing's moving all around. It's actually hypermobile and not stuck. And you can have a problem above or below it that's driving into it. So if I bump into a hypermobility, restriction on the opposite side is a good thought. Or potentially now I'm thinking, okay, this is hypermobile. What forces are coming from above or below that are now stressing this segment.
Yeah. You're looking probably at the CT junction most likely,
Mhm.
down at 5-6. If it was 2-3, then you'd probably think maybe craniovertebral.
Yeah. That kind of gets into like that next phase there is what we're going to spend a lot of time with in the next 4 modules is, right now we want you to be able to say, okay, I know there's probably something going on at C6. It could be hypermobile. It could be restricted and compressing the nerve. I have something going on there I want to treat. And then in the next modules, as we go on, like in the lumbar and cervical and thoracic, it's okay, now we start to plan going up to craniovertebral joints and then coming back down to CT junction. And to be able to look at these other segments that may be contributing to the segment of interest. And that's kind of what Jim with is so far so good in this, is to really get the clinical reasoning right about this level, and you kind of understand where we are, at that one, and we go right to the level. As we get into the other one, that's that regional influence. What regionally can be occurring? How does the foot impact the lumbar spine or TL junction is where we're going in the future. Taking all the skills and the base knowledge we've had from these first 4, and now kind of integrating it and being able to flip at it and flip it around and look at it from different directions, which is kind of hopefully fun as we get into it. But I guess the takeaway from this is you'll see that, 3 different cases, different body parts, it's kind of a similar formula of forming your differential and being able to go through the easy things and having a clear kind of picture of how do I differentiate these main categories. So you can go through this with efficiency and some confidence and then get in that search for etiologies.
Yeah. I tend to look at it as a situation, what is it that's irritable, right? What's my pain producer? That's my diagnosis. And then where did that stress come from? Why did this tissue suddenly start to break down? That's my etiology. So you have to take into consideration kind of the task that the patient's trying to accomplish, right? So, if you have somebody that's got low back pain with squatting, for instance, you're not going to start looking at a bunch of extension-based problems, right? Mm-hmm. At that point, you're less concerned about the loss of hip extension, more concerned about a potential loss of ankle dorsiflexion, right? So you start kind of seeing where these stresses go based on the activity the patient is having a hard time with. What does Diane Lee call it, Dave? Meaningful task?
Yeah, meaningful task.
Yeah.
That's what it is. Like the squatting for that person is kind of the meaningful task. It's the motion you want to look at, most closely.
Yeah.
And so you always kind of keep that in the back of your mind too. And on that side, it's also good too. And I wrap back around to that. And when they tell me that, one, in the initial eval, when I'm talking to them, I will try to repeat the thing that they expressed to me was the most important thing. Having them hear me say it and recognize it has value, that I understand what their problem is. And then at some point later on, I want to look at the meaningful task and talk about it, because no matter how, and even if I have to fix something that's tangential to it, I want them to understand that I am looking at what was important to them. And I don't take this whole process and go sideways with it. I make sure that throughout it, there's different talking points where I come back to them and what's important to them, that we'll work on this. Or in the next session, we're going to work on, you're squatting with weight or from a chair, and we're going to make sure and keep your back in a good position. I'll make sure that what's important to them, I still address, even though in my mind, I'm really going through, okay, what's most important for me to do for them. I still have to be cognizant, and it's going to, not to say selling eggs. I don't sell eggs. It's important to me as well that they understand, that value that I have. I think it's one of Rebecca's strengths. Rebecca, when you go through this with somebody, how do you then articulate to them what is their patient-centered goal or functional task?
Okay, say that again.
How do you articulate that when in your eval? And it's not so much what you say, it's that when you communicate with them, is like keeping the onus on them and what's important for them as you're assessing them and working on their meaningful task.
Are you talking about for patient compliance or for buy-in?
I'm talking about how when you want to communicate that you understand the patient's problem, and that it's that an early eval, and you want them, they have that one thing where I have trouble with walking, so maybe it's a single leg stance problem. I have pain when I'm single leg standing. Throughout your process, I know you well enough, and I probably put you on the spot here, is to know that how do you communicate with that patient throughout that eval, how do you respond to their need? How do you make them understand that you understand what their problem is and you care about their problem?
Yeah, I am a good communicator. I talk a lot through the eval about what I'm finding. I ask them if they want me to think out loud. And then I also involve them as much as possible in it. I ask a lot of questions. And then sometimes, having them go home and think about a couple things to test on their own. Okay, well, when this happens, I'm not exactly sure what's going on. I have them do some things at home when the episode is happening, so they can start doing differential diagnosis on their own too. So I think a lot of it is just treating them like they are part of the team, and that what they're finding, I have really, I just empower them to know that they are part of the whole process too. So a lot of people have been through their body problems for many, many years and have had a lot of experience. So it's not just mechanical. There's so many other things that happen with people too. One of the things that I've been able to do with people is find out a lot of, I'm so glad for the pain science that says a lot of pain is now also related with emotions. And I see a lot of people that have also a lot of mental therapy. So that's part of the process too. That boyfriend walks in the door and your neck starts hurting. It's relevant. But when you talk about their pain and what they can't do, and then also care, it makes a big difference. Does that answer some of that, Dave, that you were asking?
It's good. It's just nice to have a little bit of time to touch on, there's things that we often do that we don't well communicate. And then also kind of just to remind ourselves, because you're gonna get really good at some of these things soon, is to not lose sight of just the patient's perspective, and to kind of see it from their word as well. Make sure you're selling it so their experience is a positive one. Other than that, that's all I have, because we're at just about out of time.
Should we talk about Jim's approach to patient interaction?
I think we should. No, I don't think we should actually.
Browbeat them until they agree to what he has to say.
Yes, that is generally it. Or go away.
We don't recommend that. It's at least not right off the bat. All right.
That's why it's just kind of nice to hear our perspectives. I think this is super powerful stuff when you start getting good at it. But if you can layer on, understanding the patient, putting the patient in motion, and selling it to the patient, and they get value from you, and you're the one person who understands their problems, there's a tremendous amount of value in buy-in, and that buy-in buys you that extra time you need to really get them better sometimes. So, and sometimes that time becomes very important. So I'm always thinking, how can I buy myself time and confidence? So it gives me enough time that either one, okay, they're not better in 2 sessions, so they don't quit, or they know that, okay, when I say it takes, 6 weeks, they're like, wow, it took exactly 6 weeks. And you get buy-in. So just to use the whole playing field, not just kind of be the biomechanical wizard.
Yeah. Agreed.
Which is good, because a lot of people don't know the details of biomechanics. So you'll have both. Both are important. Everything's important.
Good. We are all set then.
All right.
Thanks, guys.
See everybody next week, huh? Have a good one.